from the audience. Please, if you have questions. You have one question there.
Yes, please.
Thank you very much, panel, for the excellent summary of PCV. I just have two very quick questions. Firstly, in patients with allergy to indocyanine green or iodine, would you recommend doing PDT just on the basis of FFA and OCT features?
Maybe I'll answer that very quickly. Yes, OCT actually is a very good way of being able to identify polypoidal lesions. OIS has delineated very good criteria for that. So yes, when push comes to a shove, the on-fast images are very useful. You can use it almost like an ICG.
Thank you. And my second question is, in patients with large polyps, after doing anti-VEGF trial, if they haven't sort of responded, is there a risk of PDT causing submacular bleed when you try to kind of, is something which, I mean, on the consent, obviously, we have to highlight. So
obviously, there is always a attendant risk of increased hemorrhage after PDT. But if you do PDT in combination with an anti-VEGF agent, that risk is greatly reduced. So for example, in Everest 2, we did not find increases in submacular hemorrhage. So while that risk is theoretical, it does exist, but it is actually less than 5%, probably in the region of 1 to 2%.
And Adrian, you do the same day, the treatment, same day treatment.
It's just because sometimes patients, obviously young patients with large polyps, they want to know the risk of anti-VEGF causing the RIP versus PDT leading to submacular
I think that's a reasonable discussion to have. And of course, I always tell patients that the worst case scenario is massive vitreous hemorrhage, which requires vitrectomy, right? But with combination therapy, that's extremely rare, actually. Unlike PDT monotherapy, in the era of PDT monotherapy, we would see it much more often.
Okay, thank you.
Yes, please.
Thank you for the great presentations. I just want to ask one question. That we, time to time, saw some patients with extrafoveal or extramacular polyps without any exudation under the fovea with a visual acuity of 20/20. But we know that these polyps can cause some submacular hemorrhages or exudations. How do you approach these patients, or what do you suggest for us to treat them? Thank you.
So probably we'll have a different approach if you ask to the panel. Usually I treat only these patients when I'm talking about Caucasian lesions. I'll treat these patients only if there is visual acuity decrease related with the exudation coming to the lesion, to the polyp. And I use anti-VEGF, and if it doesn't work, I add PDT.
Maybe I'll just add to that if it's very far away from the fovea, focal laser photocoagulation is a very good option. And you have an opportunity to destroy both the branching vascular network as well as the polyps. So it's actually a good way of ensuring disease quiescence for quite a long time. But later on, they might start to come towards the posterior pole.
You mentioned when deciding whether to add PDT, the importance to determine where the exudation is coming from, mostly from the polyp or of the network. Can you give some guidance how you evaluate the cause of the exudation?
From my point of view, we need to always do FA as well as ICG, because the FA gives you the areas of greatest fluid leakage. So you use both the FA and the ICG. Maybe I'll ask Giovanni whether you have any tips to share on that.
Yeah, I think a PDT could be, I'm not treating all the entire lesion, but just the polyps. And I have to say that we didn't say anything about laser.
No.
But I'm still using laser if you are not, of course, under the fovea. And if you gentle laser without creating any whitening of the retina, and if you look at the orange bulge, it became brownish. That I think it's still perfect. You know, it's less expensive than not PDT, and it's very effective.
Thank you, Sibel.
I have a question. Maybe Jamie can ask this question regarding the classification. We know that it's a kind of aneurysmal polypoidal enlargement of choroidal neovascularization, either secondary to age-related macular degeneration or pachychoroid disease, pachychoroid neovasculopathy. We know this from the studies, but maybe there is one more group, because according to those criteria you mentioned and other speaker mentioned, polyps with or without basal vascular network. So it means that there can be something without any choroidal neovascularization or basal vascular network. So what do you think about that? There must be 3 different classifications. Also, for treatment point, maybe PDT works well in one group than another one. Probably pachychoroid related or neovasculopathy related group respond well to PDT than AMD related group, because I do PDT for pachychoroid neovasculopathy and it works well. It's almost same for polypoidal lesion. Thank you very much.
Thank you. So the second question, I'll probably address that first because it's shorter and faster. Very good hypothesis. Many groups have found that an attractive idea. I think currently we really just don't have enough good data to really show definitive. We kind of hypothesize that's the way. Particularly using the Everest 2 data set, we didn't use hyperpermeability based on ICG as a criteria, but we did look at subfoveal choroidal thickness per se, whether that is a predictive factor, and it really didn't turn out. The one thing that was particularly significant from Everest 2 in terms of predictive biomarker is the total area of polypoidal lesion size. On the first one, I think we can talk until next year's about classification, but I agree with you. At least we know that there is the traditional AMD related. Secondarily, there is the group that is pachychoroid, and there may be other etiology. I mean, the groups that are associated with the shape of the eyeball, the macular bending, the staphyloma at the edge of staphyloma, tilted disc, all those. In itself, you could classify that into another, but there could be other as well. In fact, it is the same as CNV. CNV is a sequelae of something else happening. It could be secondary to AMD, it can be secondary to inflammatory, which we know about. So PCV is the same. We observe that final lesion, but they can come from a variety of underlying diseases. Thank you very much.
Thank you. And our last question, please.
Thank you. 2 quick questions. The first one is, how often would you review in clinic the silent polypoidal lesions? Because obviously they can come every month. And the second question is, when we switch to faricimab, since we don't have so many information as for the previous anti-VEGF, how many of you would just go for one injection and then extend, as Jenny showed? Or how many of you would just go for another loading dose? Thank you.
So the second part of the question, usually I start with 2 months after the injection. So I give 2 months. I am talking about switching. Yes.
So you wouldn't do a loading dose?
No, usually not with faricimab.
It depends on the clinical situation. So if the patient did not respond to the previous treatments, then I would load again. If the patient was dry and I'm just trying to increase the intervals between treatments, then maybe I don't need to load. But as Jemmy has mentioned, with our initial experience with faricimab, the effect actually takes a bit longer to kick in. You're not going to see it after 1, maybe 2 injections. And I believe that faricimab works, but it takes longer than some of the other anti-VEGF agents. So my preference is to load when there is still persistent fluid. Your first question, maybe you can
The first
take.
question, you're talking about silent lesion.
They never
So
lived.
I never treat these lesions. They appear and disappear.
Yeah.
So I don't treat these
How often
do you
do you
monitoring
review?
them?
actually 6 months.
3-6 months. Okay. Thank you so much.
Thank you.
Thank you.
Thank you all of you for being here today, and thank you for all the speakers for your participation. Thank you.